Hello, everyone.
Okay, so
Yeah. So we are starting.
Suchit, well done. Everything is on.
I am starting the third IHRS DNB training program, which was envisioned by IHRS and especially Dr. Ashish Nawar sir for setting up this thing for the DM and DNB training. This time, the training program will be coordinated by the electrophysiologist at the Lisi Hospital, led by Dr. Ajit Thachil sir and his team. So before we go to the main program, I would ask Dr. Ajit Thachil sir to take over from here for some. Dr. Ajit Thachil sir.
yeah, so thank you, Sujit, and we'll be hosting the program from Lisi along with my former fellow Dr. Jaskaran Singh Gujral and my current fellow Dr. Sai Krishna. But before we start the program for today, I think you'll all be aware of some sad news that our beloved Professor Mohan Nair sir passed away due to sudden death 2 days back. And it would be appropriate to remember sir at this moment because sir was one of the pioneers of EP in this country. So sir was the erstwhile professor of cardiology at the prestigious GP Pant Hospital, Delhi, and sir served as the chief of cardiology and director at Max Hospital, Delhi, chief of cardiology at St. Stephen's, Delhi, and chief of cardiology at the Asian Institute of Medical Sciences. And sir was the second president of the Indian Heart Rhythm Society and was instrumental in a large part for the 7th Asia Pacific Heart Rhythm Society being conducted successfully at New Delhi under his leadership. One of the many awards he received was this the Augustine Caspian Outstanding Career Achievement Award. So is Talwar sir here? If Professor K.K. Talwar sir is here, I would like sir to say a few words about
Good morning, sir.
Ajit, I tried calling Dr. Talwar. I don't know how he's missed it, but
okay, why didn't you speak a few words?
Yeah, sure. I think it's very somber. I never thought that I would be using this first 5 minutes of the introduction to a program to say a few things and remember Professor Mohan Nair. 2 days back, it was absolutely a sudden event and none of us expected that afternoon to hear something like this. Yeah, our association is pretty long. I knew him probably for 30 plus years, right from the day I was a resident in cardiology to wanting to do electrophysiology through my fellowship. We remembered him as a flutter man. And of course, he delved into all aspects of electrophysiology and devices. He was a welcome senior faculty at almost all meetings in not only India, but probably in our subcontinent, South Asian countries. He organized the beautiful Asia Pacific Heart Rhythm Society meeting. And there are just fond memories. All of you must have seen the outpour appreciating his work in electrophysiology and also as a person in the last 2 days. It's been very unfortunate to lose such a senior electrophysiologist who was also a good teacher. I would request on behalf of the IHRS that all of us observe a minute of silence in respect of Professor Dr. Mohan Nair. Let's pause for a moment in his memory.
From Paris.
Thank you very much. It would only be a fine tribute that the IHRS can continue its academic activities despite the loss. And I'm very happy that this time Dr. Ajit Thachil agreed to be the guest faculty for the program, and he's gathered his fellows past and present to educate the cardiology postgraduates and also possibly early career cardiologists into this program, where he's going to primarily discuss about ICD, its functioning and things like that. So without much ado, I will request Dr. Ajit Thachil to introduce his co-faculty and carry on with this program. Thanks, Ajit. You may carry on. Thanks, everybody.
So thank you, Ashish, and thank you to IHRS, and thank you all of you who are here. Today we'll be talking about the very basics of how ICDs work and how they have to be programmed to work appropriately, and how inappropriate programming can not make an ICD work. So I'm joined by my former fellow, Dr. Jaskaran Gujral, who's currently practicing at Chandigarh, and my current fellow, Dr. Sai Krishna. And I'll hand it over to Sujit to get the meeting started. The first talk will be by Jaskaran.
So, Dr. Dashkaran Singh Gujral
Yeah.
will give
Yes,
the
morning.
on understanding intracardiac defibrillation and anti-tachycardia pacing.
Yes, morning, everyone. So at the outset, I would like to thank Ajit sir as well as the IHRS leadership for giving me this opportunity. The first talk of today would be on understanding the basics of intracardiac defibrillation and anti-tachycardia pacing. So the history of defibrillation is not too long. We knew that defibrillation works since the onset of the 19th century. However, the mechanisms were well understood only in the 1930s and 40s. That led to development of the model of ICDs back in 1960s by Mirowski and colleagues. This led to the first implantation of ICD back in Feb 1980. And this is how bulky the device was. This was implanted surgically through a thoracotomy, and the device first generator was placed in the abdomen. In the last 40 years, we have come a long way, and the size has reduced to 1/5, and the procedure has become much more safer in addition to the technological advancements in the ICD. So the basic premise of an ICD is this, that is a pulse generator connected to a lead through a lead connector. The lead is what is the difference. The lead difference, as you can see, in addition to the tip and the ring electrodes that we find in a pacemaker lead, you have high voltage coils. The RV high voltage coil is present in all the leads, and in a dual coil ICD, you will also get a high voltage SVC coil. So here you have three high voltage coils, that is the RV coil, SVC coil, and then you have the device itself. It's a high voltage coil. So this device can shock through three vectors. That is, whenever energy is to be administered, there has to be two poles. So the first vector, the most commonly used vector, is from RV coil to the CAN or the pulse generator. The second vector, which is available if you have a dual coil ICD, is from SVC coil to the CAN. And the third vector, rarely used, is high voltage RV coil to SVC coil. So coming into the pulse generator, the difference as compared to a pacemaker is that in addition to the battery, there is a capacitor. So what is the importance of a capacitor is, just like a pacemaker, it is supposed to deliver charge, but it is supposed to deliver a huge amount of charge in a very small interval of time. That is within 5 to 7 seconds, it has to deliver a huge amount of charge. So it needs to stored charge and it needs to discharge it as quickly as possible. That is where the role of a capacitor comes in. Capacitor is simply a conductor which is separated by an insulator that helps in accumulation of charge and helps it to deliver it in a short period of time during defibrillation. So the defibrillation is essentially, it's a high energy shock which is delivered between two high voltage electrodes, usually from RV coil to the CAN. And the purpose is to depolarize a critical mass of myocardium. So just to recapitulate, this is how an action potential works. First is the phase zero when the cells depolarize using sodium channel influx. Then there is initial repolarization followed by a plateau phase due to calcium influx. And then there is repolarization. So one sees in the first 1/3 of the cardiac cycle is the absolute refractory period or the effective refractory period. That is where a cell depolarized will not respond to a next action potential, and later on is the relative refractory period. So what happens during defibrillation is that there will be, the cells will be in three phases. The C phase will be the cells in diastole. So the current is going to depolarize these cells. The second phase will be panel B, where the cells are already depolarized. So there will be no effect on these cells because they are in their absolute refractory period. And the third group of cells would be the cells which are in their plateau phase. So defibrillation is going to prolong the action potential of these cells. But the essential effect is that a huge amount of myocardium is going to repolarize at the same amount of time. At the same time, the repolarization is going to happen, which will lead to termination of ventricular fibrillation, because the cells repolarize at the same amount of time. This leads to termination of defibrillation. So workflow for defibrillation is simple in essential terms. First, ICD is going to sense what is happening. Then it is going to compare those sense signals to the criteria that we have fed it into it. The sensing and detection will be covered later on. Once an ICD diagnoses it as a VT, as a VF, it is going to charge and a shock is going to be delivered, right? So the essentials of shock delivery is, we all know charge is current times voltage. So the amount of energy delivery depends upon the voltage. The voltage of the ICD is higher as compared to voltage of a usual device, and it is able to carry a large amount of charge due to the presence of capacitors. So initially, the waveforms used in ICD, similar to external cardiac defibrillators, they were monophasic waveforms, which meant that the current used to flow in one direction only. This used to lead to a large amount of energy requirements in ICDs, and that is why the devices were larger, because they used to have the capacitors used to need to be bulkier in those cases. So that is why the devices were larger, and also it meant that higher energy requirements meant lower safety margin. However, this is of historical importance only. Why? Because now we have biphasic waveforms, just like in external cardiac defibrillators. In ICDs also, they work by biphasic waveforms. Initially, the current flows in one direction, and then the charge of capacitor is reversed, and then the current flows in the other direction. So this has led to the capacitor size reducing, and also it has led to a reduction in energy requirements, which indirectly has led to improved safety margin. So this is an example of how an ICD gives a shock. So these things will be dealt in later on, but I just want to focus on a few things here. This is, we can see here, there is an atrial EGM here. You can see QRS waves, atrial electrograms. And here you see an artifact here. So this artifact is a saturation artifact which happens because of shock delivery. The CD here indicates charge delivery. And then subsequently you see the rate has reduced. So the ICD electrograms will be dwelled in later on. So now we come on to an essential question: are all shocks successful? Answer is no. So the success of defibrillation depends on a large amount of factors. In addition to the energy dose, it depends upon the patient characteristics. Like in obese patients, often the energy requirement is higher. Similarly, if you have a patient who is in ACS, who is having ongoing ischemia, defibrillation may not work. And a patient who is in acidosis, in hyperkalemia, again, defibrillation is not going to work. In addition, the defibrillation dose is a sigmoid shaped curve, which means at best, we can just predict the probability of success. ED25 at this point indicates the energy at which there is a 25% probability of success. Similarly, ED50 means the energy at which there is 50% probability of success. So how do you determine what is the exact dose, what is the minimum dose of energy which defibrillator needs to give? In olden times, defibrillation threshold testing used to be performed for the same purpose. So this is when the devices were monophasic and we didn't have an idea what dose of shock, what shock is going to help and what shock is not going to help. So defibrillation threshold is the lowest energy shock which reliably defibrillates an individual patients, which means that it needs to be tested in an individual patient. The dose is going to be different for every patient. And it used to be done in two ways. The first was a step down to failure. That means that you used to start with the highest energy shock that a device can give, and then used to keep on reducing shock energies so that a shock which does not work. So that used to give us the lowest energy shock, which used to defibrillate that particular patient. The other way was the other way around. That is that you simply increase the energy of shocks and wait till a shock works. So both of these methods, as they sound like, they were very cumbersome. They required the patient to be under GA, and they were not free of complications. There were occasional incidents of stroke, even mortality happening with defibrillation threshold testing. Trials like Simple and Nordic ICD later showed that there was no routine role for routine defibrillation threshold testing with modern devices. However, one must also keep into consideration that when your pulse generator is not in the usual location or your anatomy is not usual, one may tilt towards doing defibrillation threshold testing. Like in circumstances where you have a right-sided pulse generator, if you have a pulse generator which is in the abdomen, you have LSVC or congenital heart disease, or in cases of channelopathy patients or HCM patients. So these are those group of patients where defibrillation testing may be done. The second important question is, are all shocks safe? The answer is again no. So we have talked about defibrillation threshold. So there is a window, there is a threshold below which no shock is going to work. And then there is a threshold above which every shock is going to work. That window is called upper limit of vulnerability. So a shock, if a shock's energy is above this value, it is definitely going to work. But there is a huge window, as one can see, that is between the upper limit and the lower limit of vulnerability. If a shock whose energy is between these two limits and it falls on the T wave, it can initiate VF. So imagine this, you are giving a shock through an ICD for termination of VF, and the shock works, but it reinitiates VF. So which basically means one must totally shun the practice of low energy shocks. They may help in terminating occasional monomorphic VT. They will also conserve battery life, but they are not painless. It is not that a low energy shock will be much, painless. Similarly, they will again increase the risk of additional shocks. And as I showed in the previous diagram, they may actually reinitiate VF. So they actually defeat the whole purpose of an ICD. And the only area where one can think of programming low energy shocks is when you have actually performed the defibrillation threshold. You have shown that this is, suppose 10 joule is the defibrillation threshold. You may in those cases keep the energy at 20 joule, or but in routine practices, this should not be done. So talking about success, one should also talk about downside. Shocks, ICD shocks have been associated with increased mortality. Focus on the word association. It does not mean causation. So in these patients where there was increased mortality, it's unclear whether this was because of shocks, whether it was because of a bad substrate, or because these patients had more advanced disease. All the meta-analysis, they just point that patients who had ICD shocks had more mortality. But one thing is clear, ICD shocks, they cause a lot of anxiety, they cause a lot of psychological stress. So the time has gone that ICD should only be considered as a shock box. It is more than that. And that is where the role of tachycardia pacing comes in, which brings me to my second topic, that is anti-tachycardia pacing. So before this, we need to understand where anti-tachycardia pacing works. It is essentially for ventricular tachycardia, which has mechanism which has at the center of it re-entry. So this is a basic construct of a simplified construct of a VT circuit. So you see here this is scar. As you know, for a re-entry to happen, you need an anatomical obstacle or a functional level of block, and then you need an area of slow conduction and an area of unidirectional block, so that circuit gets complete. And the blue area indicates the area of depolarization, that is the tissue which is depolarized right now. The green area is the one which is yet to be depolarized, however it is ready to be depolarized, right? So this is the direction in which the wavefront is going. This arrow head is called the leading edge, the arrow tail is called the trailing edge, and the area in between which is yet to be depolarized is called excitable gap, right? And this excitable gap is our target of anti-tachycardia pacing. Now let's imagine different scenarios of how VT circuit, of how ATP may act on a VT circuit. So this is a pacing lead. So in this case, suppose this is a defibrillation lead. This is placed in the RV, and then there is a circuit which is running. There is a VT which is going on in the nearby area, right? It is going in this direction area. So suppose the circuit is in this direction, the excitable gap is here, and this is where the depolarized tissue is here. Pacing impulse is given. Pacing impulse hits here. What happens? Nothing. Why? Because this area is depolarized. This area is in its effective refractory period. So this impulse will not be able to enter the circuit. The second scenario, the pacing impulse is delivered at the time when an excitable gap is, it is able to enter an excitable gap, but it goes in two directions. It will always go in two directions. It goes in this direction and this direction. Now, this direction, because it has quickly encountered refractory tissue, this wavefront is going to terminate because it has reached refractory tissue. But what happens to this wavefront? This wavefront, by the time it reaches here, this tissue will be ready to get depolarized, which means this wavefront is simply going to reset the tachycardia. It is simply going to continue the tachycardia which was already going on. It will just accelerate it because you are giving an impulse, which impulse is faster than the VT circuit, so it's simply going to accelerate it. The third would be, you have again hit into the excitable gap, but now at the tail end. So what happens here? Again, the wavefront, it goes into two directions, goes into the front, goes into the back. The back one, it has quickly encountered refractory tissue. So this wavefront terminates. Now, what happens here? This wavefront will travel till here, and it is going to collide with the tachycardia wavefront. So in this particular case, both the wavefronts have hit refractory tissue, and this is what is going to lead to termination of tachycardia. So you can see essentially it's hit and trial. But the slower the tachycardia cycle length, this hit and trial is going to work more often. What is essential? ATP will only work in re-entrant monomorphic ventricular tachycardia. It won't work in polymorphic VT, it won't work in VF, and it won't work in focal VTs if by default, ATP is being used in such scenarios. And So then the question comes in anti-tachycardia pacing, how many beats should you give? Should you give just 1 beat? Should you give 2 beats, 3 beats, 4 beats? How many beats? That depends upon the distance between the pacing electrode and the VT circuit. So for a panel on the left, suppose you see here, the distance is this much. What is important is the electrical distance, not the anatomical distance. So if the electrical distance is suppose this much, in this particular case, 8 impulses are required. A panel on the right, electrical distance is more, you may require more number of impulses. But what studies have shown consistently is that ATP works efficiently if you have 8 to 10 impulses per train. Then the question comes, what should be your cycle length? What should be your coupling interval of the anti-tachycardia pacing as compared to the VT? So it has to be faster than the VT cycle length because it has to enter into that circuit. The usual ATP cycle length is kept at, coupling interval is kept at 81 to 88% of the cycle length. Then ATP can usually be of two types. So vision this. This is the tachycardia which is going on. This is RR interval. This is 400 millisecond, around 150 beats per minute. So this is, let's assume it's a VT going on at 150 beats per minute. In this particular case, you start giving ATP, that is denoted by S1, at a coupling interval of 320 milliseconds. So which will approximately come to 80% of the cycle length, and you are giving impulses. As you can see, the coupling interval between the impulses is fixed. So this is called a burst. In burst, the intercoupling interval between the trains will be fixed. Another type of ATP is possible, that is called ramp therapy. In that, the coupling interval between the pacing impulses is going to have a decrement. That is, it is going to reduce. Usual decrement that is set is 10 milliseconds. So here you can see the pacing impulse coupling interval is reducing by 10 millisecond in every beat. This is called ramp. It's similar to an inclined ramp that we talk. So usually we prefer burst pacing because trials have shown a lower chance of acceleration of VT. Now you can have different response to ATP. Like the first slide I showed, you may not capture the circuit. If you are pacing at a slower cycle length, you may not capture the circuit. You encounter refractory tissue in between the cycle length, in between the circuit and the pacing impulse. You will not capture the circuit. You may enter the circuit, but you may simply continue the circuit, as the second slide that I showed. And the third would be, you have reset the circuit, but you have also terminated both the wavefronts. That is the third slide that I showed. So this is how an ATP looks like. There'll be more discussion on this later on, but this is just a representative diagram. You see here atrial marker channels and ventricular marker channels. One can see, just see the marker channels here. You can see there are more V's than A's. So this is VT, right? And then you see here V pace happening. This is anti-tachycardia pacing which is happening. You see here there are 7 impulses of anti-tachycardia pacing, and what happens after anti-tachycardia pacing? There is termination of ventricular tachycardia and resumption of ventricular pacing later on. So what factors actually determine success of an ATP? They depend upon the site of pacing. How far is it from the VT circuit, right? Most important factor is the cycle length of the tachycardia. If the cycle length is longer, that is the tachycardia is slower, excitable gap, it will be easier to enter into the excitable gap. Similarly, if the patient is on beta blockers, they will increase the success of anti-tachycardia pacing. ATP has been conventionally meant for patients who have slow VT, that is defined as a VT less than 188 beats per minute. Air success rate ranges from 80 to 94%. However, in the pain-free 2 trial, it also showed that even in fast VT, it works in up to 77% of the patients, which means that a patient where otherwise shock would have been given, those patients would, the VT would terminate simply with an ATP. So obviously it improves the quality of life. It improves the longevity of device. This has been shown in the pain-free 1 and the pain-free 2 trial. Similarly, one may contemplate that what happens, if you give ATP, there may be the tachycardia may not terminate, the patient may collapse, the patient may die. So there have been the pain-free 2 trial. This data has been taken from pain-free 2 trial, and this has again showed that the amount of syncope is comparable between the ATP arm and the shock arm. The mortality is comparable between the ATP arm and the shock arm. So ATP is a safe and effective alternative to ICD in slow VTs and in some fast VTs. However, like there are two aspects of every coin. So here also, you may do ATP, it may not work. Similarly, it can also accelerate tachycardia. That happens in around 2 to 4% of the cases. It may degenerate VT, monomorphic VT to polymorphic VT or VF. It's a rare recurrence, but it can happen. And since you have programming ATP, this will be dwelled in later on in the talk. They will also cause a slight delay in the shock delivery. But in the trials, it has not shown to be significant to cause syncope. The usual scheme of ATP is this. Usually bursts are kept first up because they are likely to cause less acceleration. We usually keep 2 to 4 bursts at around 81 to 88% of cycle length. So they have to be faster than the VT. And then decrement may be kept with a 10 millisecond decrement. That is, every burst will be at 10 millisecond faster cycle length. And then one can program ramp at 91%. So some people also keep ATP even in the VF zone. This is why, because the device does not know whether tachycardia which is VF zone is actually VF or not. So in many cases of tachycardia in VF zone, they are actually fast VTs. So ATP during the time of charging, ATP can actually terminate VT, and also it won't increase the charging time. So a shock will also be delivered if the ATP does not work and redetection is confirmed. So to conclude, first and most important, we must remember only maximum energy shocks should be utilized because of risk of failure, recurrent shocks, and reinitiation of VF. The goal of ATP is to terminate VT and avoid unnecessary shocks. ATP are also effective and safe in the fast VT zone. Thank you.
Thanks, Jaskaran. Suchit, can you take over?
Thank you for that nice talk and covering the aspects of the physiology of VT induction and also the shock and ATP. So I think most of the so you have already discussed that it is safe to give ATP and shock also. So what are the scenarios where shock can fail? Can you discuss? If you have given a shock but it is failing to convert the VF.
So, sir, in cases like some patients may have an elevated defibrillation threshold, like if a right-sided SPC, right-sided ICD is there, or in patients with LSVC. So, in patients with HCM, in patients with obesity. So these patients, they are known to have higher defibrillation thresholds. And then, of course, if you're, R wave during ventricular fibrillation, there is undersensing of ventricular fibrillation. Then, of course, shock thing.
So, Dr. Talwar, sir, please, any question on this? So you have to unmute, sir.
In the meanwhile, Jaskaran, can you exclusively program either pacing only or shocks only in any of the zones, or you need to make a proportion of them, and why?
Yes, sir. We in the slow VT zone, suppose we are in the monitor zone. We are in the slow VT zone around 150 to 160 beats per minute. In patients of ARVC, we can program ATP only zone. We can program monitor only zone also, where no therapy will be delivered. And in patients of channelopathy, like where we expect that VT is not going to happen. So in those cases, we can program a VF only zone and keep only shocks there because we know ATP is not going to work in presence of VF.
Yes.
I'm not sure if that's what Ashish meant.
Yeah, that's right. You're right, Ajit.
I think what Ashish meant is, can we program ATP without programming a shock? Yeah,
that's the relevance.
certain devices allow, certain devices don't. Medtronic devices do not allow you to program an ATP without a shock because they assume that any ATP that you deliver can also be proarrhythmic, so you must be able to follow it up with a shock. But in Biotronic or St. Jude devices, you can do that. You can only for the the VT1 and VT2 zones. In the VT1 and the VT2 zones, in Biotronic and St. Jude device, you can program an ATP without programming a shock. So the device there makes the assumption that if the practical relevance is supposing somebody has a slow VT at 150, patient is not collapsing immediately. You don't want to give a shock for this. You want to give ATP. If it doesn't revert with ATP, you don't want to give a shock. If you want to do that, you can do that with a non-Medtronic device. That is, you can program only an ATP without a shock for the 150 VT, the relatively slower VT. But you cannot do that for the relatively faster VT. I think that's probably what Ashish meant.
Yeah, exactly. And the second, yeah, Dr. Talwar, yeah.
No, I think Ajit, if I remember, there is one Medtronic because we recently had a patient who was getting VT around 130 rate. And so we had to overdrive, but I think he will get a shock even at 130. So we thought he was keeping his pressure sort of comfortable. So we did try to off the VF therapy the shock therapy in that. I think this is there is a possibility in the Medtronic also. This is some months back that a patient was with us. Anyway, I had to recheck it.
Okay. The other concept that probably Jaskaran could also introduce was the ATP during charging and ATP before charging. So that's another little thing in the VF zone where you want to terminate if it's a fast VT by ATP. So if it is programmed to before charging, it tends to save the buildup of the charge in the capacitor and that way help to not expend the battery. Whereas
I think Ashish, he mentioned about this in his later part. He did mention you can keep on ATP if the rate is like VT during that time of charging. I think he did mention, but if you allow, because of paucity of time, because you have to finish
yes,
it,
yes.
that you said, Ajit also has a similar kind of programming issue. So can we go ahead so that we can have?
That's right. Sure.
Dr. Ajit.
Yes, sir.
Welcome, and I think Ajit doesn't need introduction to this crowd. So I'll be proud of his work. Ajit, over to you. I think let us hear ICD detect ventricular arrhythmias and how to effectively program. I think this will also help what she's asked the question later on. Okay, to you, Ajit, please.
Thank you, sir. So the two questions we're going to address is how does an ICD detect VT or VF? And how do you program an ICD to make it work effectively? I'll try and keep it as basic as possible. So the relevance is this: the inappropriate implantable shocks were 31%. 31% of all shocks in MADIT2 were inappropriate. And appropriate programming can reduce the inappropriate shocks for SVT from 2 to 4%, and inappropriate shocks for VT, that is the VT which could have been terminated by ATP which got a shock, that's still called sort of inappropriate, to 5 to 25%. So how do we do this? So for that, let's first understand how does an ICD make a diagnosis of ventricular tachycardia and then how to program. So when we look at the ICD has these polarities. So it has to diagnose diagnose an R wave and to diagnose a P wave. To diagnose an R wave, it can use this. It's called the tip to ring, which is the standard thing used to diagnose the R wave. What is used to diagnose the P wave is this. Again, the tip to ring of the atrial lead. So these are called the near fields, ventricular near field and the atrial near field. Now, there is also something called an integrated bipolar, which is rarely used these days, wherein you can measure the R wave from the tip to the RV coil. This is usually not used these days. It can give a bigger, bigger R wave than the true bipolar R wave, but it may cause oversensing. It's currently available only in Medtronic and gently not used, so I won't discuss about that. The ICD can also record in other vectors, that it can record far fields, that is very far apart. So it can record tip to CAN, the RV ring to CAN, it can record the RV coil to CAN, and it can record from the CAN to the SVC coil. These are called the far fields. These, as you may imagine, will look more like standard surface ECGs. And these are used to discriminate. The shape of these things are used to discriminate if it is SVT or VT. So this is the basic way in which ICD has sensing polarities. Now, how are these sensing polarities configured? So this is what I said, is the true bipolar, which should always be used. There is also an option of the integrated bipolar, which will give a larger R wave, which is generally not recommended. You can change it in Medtronic devices. But what is more important, just a very basic thing, that sensing is always from the right ventricle. Even if it's a CRTP or a CRTD, sensing is always from the right ventricle. The other part which we need to understand about sensitivity is how it works. Now, if you were to look at an older generation pacemaker, any number below a particular number will not be sensed. Any number above a number will be sensed. So look at this schematic where a sinus rhythm may have a larger amplitude, a PVC may have a smaller amplitude, and a VT may have an even smaller amplitude, in which case the ventricular tachycardia will not be sensed. Why does this happen? Mostly because of vector orientation, not because of the absolute R wave at that point. For example, sinus rhythm is in this direction, PVC may be in this direction, and ventricular tachycardia may be in a totally different direction. So because of the change in the vector, this is the sensing electrode, this bipole. So if the ventricular tachycardia goes orthogonal to the sensing bipole, the ventricular tachycardia may still not be sensed. And VF is worse because VF inherently will have lower amplitude and they'll be constantly changing vector orientation. So the way of sensing in pacemakers will not work in ICDs. So for example, this is VF. Some of these are not even sensed because there are changing amplitude and vector orientation. So and you cannot simply reduce that sensing number from 0.5, 0.3, 0.6, 0.2 to make the device sense ventricular fibrillation, because then this will happen. It will start sensing things other than the R wave. For example, here, it is sensing the T wave. So sinus tachycardia will now be called ventricular tachycardia because every sinus tachycardia is double counted. If a patient has a sinus tachycardia at 100, it will be sensed at 200. So you cannot really change the sensing threshold. So we need to have another idea. So the idea is dynamic sensing. So for example, we have this QRS complex. The sensitivity starts at a certain percentage of sensed R wave. It will vary from manufacturer to manufacturer. It's about 50 to 75%. And then there's a refractory interval. You do not sense 100 milliseconds after a V-sense event and 150 milliseconds after a V-pace event, because otherwise you might sense the same event again. So after the refractory interval, you start sensing. And when you start sensing, you start at a particular percentage of the sensed R wave. So this takes care of the variations in RR intervals, the variation in the RR height. And then it gradually decays to the program sensitivity. The program sensitivity here is 0.3 to 0.6. When we say 0.3 to 0.6, that means that this number is somewhere between 0.3 to 0.6. If you were to keep 0.3 to 0.6 here, you would sense this T wave. This decay allows us to maintain the low sensitivity after the T wave has elapsed, but at the same time not sense the T wave. So this is how ICD sense. So this has some implications in understanding the electrogram. Nowadays, most pacemakers also sense like this. So the first step is sensing the R wave, which I just mentioned. Then it has all these steps. Now, a tachycardia may be an SVT or it may be a VT. So it has to detect a tachycardia. And then after it detects a tachycardia, it has to discriminate the tachycardia as an SVT or a VT or a simultaneous SVT and a VT. That's also possible. Then it has to deliver a therapy. After delivering a therapy, it has to check, has the tachycardia terminated or is the tachycardia still going? So this is called termination criteria and redetection criteria. And then it has to, then it will start charging. For example, if it has to deliver a shock, it will start charging. And after charging, just before delivering a shock, it will confirm that tachycardia is indeed still going on. And then it will go on to deliver the shock. So this is the sequence in which the ICD works. So the problem is the default programming in the ICD does not work in most of the patients. So we need to really find the exact programming for the particular patient. So we need to make sense of all these numbers. These are the numbers that we see on the ICD screen. So first thing, detection. Every RR interval is classified by the ICD as being in the ventricular fibrillation zone or the ventricular tachycardia zone or the sinus zone. So for example, in this particular example, anything from 150 to 200 beats per minute, that is 300 to 400 milliseconds, is called the VT. And anything which is more than 200 beats per minute, that is cycle length less than 300 milliseconds, is called VF. It may not be VF. It's just whatever is in the VF zone is called VF. And anything which is slower than this cycle length or slower than this rate is called a sinus. It's called VS. Now, when you look at the detection, you will see these numbers in all manufacturers. You look at the way these numbers are written. There's a zone called VT1, a zone called VT2, and a zone called VF. In VT1 and VT2, you see only one number. This is the NID, or the number of intervals to detect. But whereas in VF, you find two numbers, 20 out of 26 or 8 out of 12. 8 out of 12 is to redetect a tachycardia after the therapy is delivered. 20 out of 26, the initial detection. So what's the difference between these two? So in Medtronic, there's one more additional step. There is something called the FVT also, fast ventricular tachycardia. So FVT can be configured via VT or via VF. So FVT via VF means the detection and therapy rules for FVT are like VT. So let's see what all these numbers mean. This means that anything less than 140 beats per minute, going on for 40 beats, is called a sinus rhythm. Anything between 140 to 150 beats per minute, continuing for 36 beats, is called a VT in the monitor zone. Anything between 100 and 182 beats per minute, if it is 18 out of 24, I'll just explain what is 18 out of 24. No, sorry, this is via VT, meaning the rule for fast VT is like VT. So anything between 150 to 182, going on for 36 continuous beats, that's because it's via VT, is called a fast ventricular tachycardia. Anything above 214 beats per minute, satisfying the 18 out of 24 rule, is called a ventricular fibrillation. Whereas if you program like this, FVT via VF, this means that anything between 133 to 150 is monitor, 150 to 200, so it reads from this number to this number. 150 to 200 is called a ventricular tachycardia. It needs 28 beats. 200 to 222, you have to read from top to bottom. 200 to 222 is called a fast ventricular tachycardia. And the diagnostic criteria for fast ventricular tachycardia here will be 18 out of 24. Now, what is this 18 out of 24? So this counting is called a consecutive counting. It's self-explanatory. The program number of consecutive beats within the detection range, which should be reached to diagnose a ventricular tachycardia. Whereas this is called a probabilistic count. That is, see, here there is ventricular fibrillation going on. These wavelets are too small to be sensed. So this means that the ICD is seeing wavelet number 7. It's after that it is seeing only wavelet number 9, but it counts it as 6 because this is too small an amplitude to be seen. So this is not seen by the ICD. So the ICD is detected 1, 2, 3, 4, 5, and this is number 6, this is number 7, and 8, 9, 10, 11, 12. Now, what happens when the ICD detects only 5 and 6? As far as the ICD is concerned, the RR interval between 5 and 6 is from here to here. So it's a long RR interval. This RR interval is sinus because it's a very long RR interval. And the RR interval between 7 to 8 is from here to here. For the ICD, this RR interval is also sinus because a long RR interval. But there we have this safety margin. That is, if 12 out of 16 RR intervals fall in the VF zone, it is called a ventricular fibrillation. So that helps to, that's called the probabilistic count. So all ventricular fibrillation will be in a probabilistic count in all manufacturers. So that's the 12 out of 16 or the 24 out of 36 or the 30 out of 80. Whereas the other one where you see only a single number, it's a consecutive count. Now, next thing you need to read is understand what those annotations mean. Always on the beginning of the electrogram, it will be written on the top what it is. This is the RA near field. A tip to A ring means RA near field. RV tip to RV ring means RV near field. Then there'll be the AA intervals here, 760, 760, 760, 760. The VV intervals here, 520, 510. This means that the VV interval is faster than the AA interval, so it's likely to be a ventricular arrhythmia. Then there's a marker channel, so it writes what it is. VS, VS, AP. VS means sinus rhythm, AP means atrial pacing. And just because you have two channels, it doesn't have to be atrium and ventricle. You have to read what is written here. It's written here, CAN to SVC. CAN to SVC is one of the far fields we talked about. So this is the RV far field, CAN to SVC, and here's the RV near field. So the marker channels are and the AA and the VV intervals remain the same. So all I'm saying is, because you have two channels, don't assume that they're A and B. Just go and read what is written on the left of the channels. And then here are the annotations used by all companies. Sinus and monitor zone rhythms are written VS. Any tachycardia in the VT zone is written TS. A tachycardia in the fast VT zone, which is applicable only for Medtronic, is called TF. A tachycardia in the VF zone is written FS. This is before the tachycardia is diagnosed. Remember, to diagnose a tachycardia, you have to satisfy so many numbers which fall in that R interval. Once a tachycardia is diagnosed, it's changed this labeling to this. VTM, that's a monitor zone VT diagnosed. TD, meaning ventricular tachycardia detected. FD, meaning ventricular fibrillation detected. SVT, meaning any type of SVT detected. AF means SVT meeting AF criteria detected. ST means SVT meeting sinus tachycardia criteria detected. And SVT plus VT means any type of SVT along with a ventricular tachycardia. That's a dual tachycardia has been diagnosed. While giving therapy, it will write one of these three things under the therapy. TP, that is anti-tachycardia pacing. CE, that is the charge of the capacitor has been enabled. CD, the charge of the capacitor has been delivered. And during pacing, it will write one of these things. VP, meaning ventricular pacing, which is only RV pacing. AP, meaning atrial pacing, and BV, meaning biventricular pacing. So you know what these short forms mean, because this is the short form that the ICD will write. So let's look at what we are seeing here. So if you look at the bottom channel, it's VS, 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 VS. So either sinus rhythm or monitor zone. AP, 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 AP. So atrial pacing. Atrial pacing is going on at a cycle length of 760. The ventricular is dissociated from the atrium. The ventricle is going on at a cycle length of 510. So that is a ventricular arrhythmia, a rather slow ventricular arrhythmia. Now see what happens. It is detected a VTM, a VT in the monitor zone. After the enough number of VS was satisfied, it changed the annotation to VTM. So it's found a VT in the monitor zone, and it didn't do anything. Waveform suspended for 34 minutes because in the monitor zone. After the VT is still continuing, but the ICD doesn't do anything. Now look at this. VS, 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 TS, 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 TS. So ICD is detected tachycardia in the ventricular tachycardia zone. TS, TS, TS goes on for a pre-specified number of beats, then it changes to TD. So ventricular tachycardia is detected. And as soon as it's detected, it goes to TP, that is anti-tachycardia pacing is started. TP, 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 TP. And then it is a VP, ASVP. Because there is no AV conduction after the ventricular tachycardia is paced and terminated. So here is another one, VS, VS, TS, one beat in the ventricular tachycardia zone, then TF, 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 TF. That means subsequent beats in the fast ventricular tachycardia zone. A dot or an asterisk here means that the capacitor is charging. And then TP, TP. So it's trying anti-tachycardia pacing. While it is trying anti-tachycardia pacing, it is also charging the capacitor. Here's another one. ASVS, 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 meaning likely sinus rhythm, ASVS, and then an FS, a beat sensed in the ventricular fibrillation zone. FS, 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 FS. Enough number of beats sensed in the ventricular fibrillation zone. Once you sense enough number of beats, it changes the annotation to FD, ventricular fibrillation detected, and then TP, TP, TP. So ventricular fibrillation burst before charging. You can burst the anti-tachycardia pacing before charging or during charging. So TP, TP, and then ASVP. So it is sinus rhythm in the atrium and ventricular pacing in the ventricle. In this case, this is APBV, that is atrial pacing and biventricular pacing. So it's all the different annotations you will find. Now, if you look here, this tachycardia, the atrial channel shows AS, AB. I'll shortly explain what is AB, but you can see that the atrial intervals are 210, 220, 210, 220, 230, 260. it is faster than the atrial tachycardia detection rate. That's programmed separately. All things with an atrial channel have an atrial tachycardia detection rate, which is the AF detection rate. So because it is faster than that rate, it is detected an atrial arrhythmia, atrial tachyarrhythmia. But at the same time, it is also saying TS, 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 and then TD. So it's also detected a ventricular tachyarrhythmia. So finally, it says VT plus SVT, that I have detected a atrial tachyarrhythmia as well as a ventricular tachyarrhythmia. So here a ventricular fibrillation is detected, FS, 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 and then FD, ventricular tachycardia, is detected. And after it is detected, it will change the annotation to VS. It doesn't mean that it is not detecting something. It is already detected. So subsequently, it will just say VS. And then it will start charging at this point. It has finished charging here. That's called charge enabled. And then it is delivered the charge, CD. After it's delivered the charge, it is VS, 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 VS. So likely sinus rhythm. Now, here, the tachycardia is the atrial cycle length is 180, 170, 180, 170, 180, 170. The ventricular cycle length is 360, 360, 360. But look at this. The device is at AF, meaning it has detected atrial fibrillation, but it is not changing the ventricular annotation to TD or VT, which means that the device is diagnosed that this is an atrial tachyarrhythmia with a 2:1 AV conduction and not an atrial tachyarrhythmia with a simultaneous ventricular tachyarrhythmia. So that's what this annotation means. If it was a simultaneous ventricular tachyarrhythmia, like in the previous example, this TS would have changed to TD. TS simply means that tachycardia has been detected. It is not yet been discriminated as an SVT or a VT. So now, how do we use all this information to program? So these are the standard things that we need to program. I told you about the detection numbers. Now, look at this example. Okay, the atrial near field on top and the ventricular near field at the bottom. The marker channel here, AS, AP, AS, AS. The atrial cycle length is around 1,200, whereas the ventricular cycle length is around 570 to 580, meaning ventricular is faster than the atrium, so it's a ventricular tachycardia. But see what the device sees. VS, 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 meaning sinus rhythm. TS, 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 meaning in the ventricular tachycardia zone, and then VS. So what has happened? This beat is 430. The ventricular tachycardia has become slower for one beat, 430. Now remember, our detection criteria here is 430. Okay. Now this ventricular tachycardia slowed down to 430 for one beat. Now this is a consecutive count. So how does it count? And remember, this is the count we have to satisfy. You have to satisfy 36 beats at 430. So let's see what this device is doing. It's satisfied 1, 2, 3, 4, 5, 6 beats at 430, more faster than 430. The next beat is 430. So what happens to the count? 1, 2, 3, 4, 5, 6, 0. It goes back to 0. That's how a consecutive count works. And then 1, 2, 1 again 0. Sorry, 1 again 0 because VS, it's slower. 1 because it is faster. Again 0 because VS. 1, 2, 0. So what is happening? The ventricular tachycardia is oscillating just on this side and that side of 430. So it goes on like that. 1, 2, 3, 0, 0, 1, 0, 1, 0, 1, 2, 0, 1, 0, 1, 2, 0. This goes on like that. 1, 2, 3, 0, 1, 0, 1, 0, 0, 1, 0, 0, 1, 0, 0. So finally, the tachycardia terminated here. This tachycardia actually went on for 1 hour. So the lesson here is a ventricular tachycardia straddling the VS and the TS zones, VT will never be declared. So program a detection rate to at least 20 beats lower than the ventricular tachycardia rate in secondary prevention. So if you know that what's the rate of the clinical VT, program at least 20 beats lower than the clinical VT. Longer NID helps to not treat self-terminating tachycardias. Here is a self-terminating rapid ventricular arrhythmia. Because the NID was longer than this, it did not give an inappropriate shock for this. If the NID or the number of intervals detected was shorter, it would have given an inappropriate shock for this tachycardia, which would have terminated. So how long can you put the NID, the number of intervals detected? There's a trial called the MADIT rate. It looked at 3 options. One is a 2 point, it's a Boston ICD. Boston ICD uses time, seconds, rather than number of intervals. So it used 2.5 seconds, 170 beats, 1 second, 200 beats. These are both called the conventional arm. 60 seconds, very, very long, 170 beats, called the delayed therapy. And then 2 more arms, 2.5 seconds at 250 beats, or 12 seconds at 200 beats, all called high rate therapy. And they found that the delayed therapy and the high rate therapy had less inappropriate shocks. And in this study, at least, they also had less mortality, suggesting that shocks cause mortality. But the take-home message is for VF programming, for patients who might tolerate VF this long, many patients will, especially for primary prevention. For Boston Scientific, it should be more than 200 beats per minute, at least 2.5 seconds, which is not the default. The default is 201 seconds. You can go up to 220 also. Others, it should be more than 200, typically more than 220. It should be 30 out of 40 beats at least, or at least 24 out of 30 beats, ideally 30 out of 40 beats. VT zone programming for primary prevention, again for patients who you think might tolerate, most patients are expected to tolerate. For Boston should be 170 to 220, 5 seconds. Others should be 170 to 220, somewhere between 30 to 36 beats. Monitor zone for all manufacturers, it should be on. In Boston, the recommended would be 130 to 170, 5 seconds. Others would be 130 to 170, 36 plus beats. Now, other than Medtronic, other manufacturers don't have a genuine monitor zone. So we like to use this VT1 zone as a monitor zone by switching up therapies in this zone. But if therapies are required in this zone, for example, you want to treat a ventricular tachycardia at 150, then you will have to put on therapies in this zone and you will have to forego the monitor zone. Whereas in Medtronic, there is a dedicated monitor zone. You can put on the monitor. Now, the next part is discrimination. How do you discriminate a tachycardia as SVT or VT? You use these 3 features in all manufacturers: onset, morphology, and stability. In dual chamber ICD, you also use A and B relationship. So onset means a sinus tachycardia will start slowly. A monomorphic ventricular tachycardia will start rapidly. Onset basically means that if the percentage change in the RR interval is more than a particular number, this is likely to be ventricular tachycardia. Compared to the previous RR, if the current RR is faster by a particular number, this is likely to be monomorphic ventricular tachycardia rather than sinus tachycardia. In sinus tachycardia, each RR will only slightly be faster than the previous RR. Stability means there are more RR variations, means that the RRs are unstable. This means it's AF with fast ventricular tachycardia, or atrial tachycardia with less than 1:1 AV conduction, rather than a monomorphic VT where the RR intervals are stable. So the typical number uses 50 milliseconds. Electrogram match or wavelet is what we use the far field for. I'll shortly come to that. PR logic combines that's the name used by Medtronic. Others have equivalent names. Combines features of AV relationship. For example, V faster than A is ventricular tachycardia. A faster than V is supraventricular tachycardia. So onset should be programmed on if relatively slow sinus rates are expected, but it should not be programmed on if you think that there will be sinus tachycardia. For example, hypertrophic cardiomyopathy, young patient programming for VT onset should be off, because patient is likely to get ventricular tachycardia during an ongoing sinus tachycardia. So in that situation, onset will misdiagnose a ventricular tachycardia because the percentage change from the sinus tachycardia to VT will be less. The usual number used is an 81% change. Now, the other thing which you need to understand only with Medtronic is that Medtronic discrimination is sequential. For example, if it says onset is SVT, it will not look at stability or morphology. If stability says SVT, it will not look at morphology. But if onset says VT, it will look at stability. If stability says VT, it will go to morphology, which means that if you put all 3 on, but if onset says SVT, the other 2 are as good as being off. Stability compares the RR variability between beats. I will not go into how it is. And the third thing is wavelet. So the far field is converted into a digital waveform like this, which is given a particular score. And the stored digital waveform is compared with the digital waveform during tachycardia. The match is scored. And if there is no match, it is called a VT beat. If there is a more than 70% match, it is called an SVT beat. If 3 out of 8 beats have more than 70% match, the entire sequence of tachycardia is called an SVT. So this is how you'll get all of these after the therapy is delivered. You'll get the QRS, which is the QRS of the tachycardia, and the template is the dotted line, and there is no match in any of them. It's not perfect. It will work in about 85 to 95%. Now, how do you combine all of them? In Biotronic, if you put each of them on, that means all of them should be satisfied. That is onset plus stability plus morphology on means all must. In Boston, you can either put on onset plus stability or morphology. St. Jude gives you the options. Once you turn it on, it will ask you this way. If the active SVT discrimination, if all the active discrimination criteria indicate VT deliver therapy, or if 2 out of 3 indicate VT deliver therapy, if any of the 3 indicate VT deliver therapy. So the moment you turn on in St. Jude, it will ask you this particular question. St. Jude also has an additional feature called chamber of onset. Here's an anti-tachycardia pacing being delivered. After that, a tachycardia is started with an atrial electrogram. This is a far field A, this is a far field B. So if you could use this feature and see which chamber the tachycardia started, you should be able to say which tachycardia it is. This feature is available only in St. Jude. Dual chamber discrimination, it is always on, and this is what it says. V more than A is VT, V less than A, and V equals A or SVT, or it may be SVT plus VT. That is, the RR intervals are regular, but the PR intervals are different. This means that the atrial rate is different from the ventricular rate. It will call it SVT plus VT. But there is a problem here with dual chambers. For example, look at this tracing. This is an atrial sensing. There is a ventricular pacing, and you can see another deflection in the atrial channel corresponding to the ventricular sensing. What is this? This is a far field R wave sensing by the atrial channel. This is not genuine atrial arrhythmia, a genuine atrial event. If it were to sense this as a genuine atrial event, it will say that the atrial rate is 300. From here to here is 300. So to prevent that, there is something called a post-ventricular atrial blanking, which means that any event which falls within 50 milliseconds of the ventricular event, any event in the atrial channel which falls 50 milliseconds after the ventricular event will not be sensed. And if it's more than 250, it will be sensed. So this can cause a problem.
Sorry to interrupt, if we can.
Yeah. I'll just so I'll just come to the conclusion. So how do you do all these things on? Well, this would be the default programming. I told you what the default programming is: 170 to 220 and more than 220 VF. For secondary prevention,
the zone programming, what ideas you have on that? That maybe.
Yeah. So just this. So the severe LV dysfunction, I would program to a slower zone. That I would treat VT at even 150, meaning I think the patient will not tolerate that. If the LV dysfunction is not all that bad, I would treat only at 171. And if it's something like a Brugada where I'm going to get only VF, I'll put all of these off. I'll have only the VT zone on. So I will stop with that. Thank you.
Yeah, Dr. Talwar, if you could take over.
Thank you, Dr. Ajit, I think for explaining so well detections and then sensing and another programming issue. I think we can have few questions before we go to the cases here. Anybody likes to say anything on this?
Yeah. So Ajit, I'm sorry that I interrupted you, but you could expand on when do you program 2-zone versus 3-zone?
Yeah. So ideally, for secondary prevention, I will need 3 zones, because for secondary prevention, I will have to treat slower ventricular tachycardias. For example, a patient has had a ventricular tachycardia at 160 or 170 beats per minute, and I'm putting an ICD. Now I want to treat a VT at 150 because the clinical VT is 170. So in that case, I'll have to start treating from 150. I will need 3 zones. I'll need a zone of somewhere around 150 to 180, another zone of somewhere around 180 to 210 or 220, and a third zone of around 210, 220 plus. Whereas in primary prevention, I would need only 2 zones. I would start treating only from 170, and I'd keep that 130 to 170 as monitor.
Another reason for 3 zones could be that you know that there are 2 clinical VTs of different cycle lengths. So then once again, you might have to split.
Yes, whenever we are suspecting a slower VT to happen, we put 3 zones.
Right, sure. Suchit?
I think it's okay. No more questions. Move over to the next.
Sure. So Ajit, I think everybody is interested in the cases that you can choose to present 2 or 3.
We have half an hour, I think.
Yeah.
Suchit, we can take the first case. Yes, yeah.
Yeah. First cases will be by Jaskaran.
I think Dr. Jaskaran Singh Gujral, can you just present the first troubleshooting?
I'm sorry, the first case is by Sai.
Yes.
Sujit, I made a mistake.
I think
we have
we
Sai
can go to
presenting the first case.
Yeah, just Karan, you can stop. Yeah.
Dr. Sai, yeah.
So if everybody goes through quickly, we can have all the three on.
I'd rather go slowly and learn it. Let's see.
Okay, sure.
And have only two if it.
Your take. Yeah.
Good morning, sir. Thank you, IHRS, for giving me the opportunity to present here. So I'll
Full
be
screen.
basically. Hello.
Can you make
Go
it
on.
full screen?
Oh yeah, go to presentation mode. It's not in presentation mode.
No.
Uh,
Below there is a marker, no? No.
that one, right?
Yes. Correct.
Yes.
So I'll be discussing the importance of analyzing intracardiac EGMs, interval plots, and then lead parameters, and looking at the trend of lead parameters in troubleshooting ICDs through examples. So this is one 55-year male who had a dual coil single chamber ICD, Boston Scientific, for secondary prevention. So what is being displayed here is called as start screen. And then when we see this, we'll have to answer 4 questions. That's what we look up in the screen. So first, what are the channels being displayed? So you can see here, it's labeled as leadless or far field. So what it means is, as was already discussed, it displays far field, which is from RV coil to CAN, or if it is dual coil, it could be SVC coil to CAN. And the other thing is near field. And the second question to be answered is the near field dedicated bipolar or integrated bipolar? And now, because except for Medtronic, almost all has only dedicated bipolar. So it is understood that it is from RV tip to RV coil. And the other thing is marker channel. So marker channel is what is ICD thinking of what is being seen in far field and near field. So this is how it will be. And then look at what all signals you are seeing in far field and near field, and is all the signals being seen by the marker channel as by ICD also. And then see if the signals are being appropriately labeled by the ICD in the marker channel. So now if you see, we have very high frequency, almost non-physiological, like instantaneous signals happening, and then bizarre signals, which are intermittently seen in both far field as well as near field. So for device, if such non-physiological, bizarre, intermittent signals being seen both in far field as well as near field, it is labeled as noise, which is appropriately detected by the device as noise by noise reversion algorithm. So this is appropriate function by the device. So any high frequency non-physiological signals which are seen in both near field as well as far field is being labeled as noise by the device, which is being correctly labeled here. And this is other case where a 60-year female had implanted dual coil AICD for secondary prevention. She presented to us with recurrent ICD shocks. This was on a rainy day. She actually thought it's a thunder strike and then presented to us next day. So on evaluation, her lead parameters were normal. And then we had a suspect, and the EGM, which was not being displayed here, had shown it as EMI, but being inappropriately given shock. So what we did is we went to the home of the patient and then repeated the maneuver where she had ICD shock. So what she was doing during a rainy day was she was standing near the window and then catching the window. And that time she had shocks. So we repeated the same maneuver, and then you can see the recordings here. So you can see very high saturated signals in 2 channels. The upper channel is CAN, SVC coil to CAN, and the second one is SVC RV coil to CAN. So these are 2 far fields, and the other channels which were near fields are not showing this signal. So as I already discussed, for ICD, to label it as noise and to halt to the therapy, it should be seen in all the channels. The problem here is, though it was an EMI, it was because not seen in all the channels, it gave shock, so which was inappropriate. The reason for why is it being not seen in the bipolar near field is probably because grounding was not good, and then the current was very minimal, the grounding current, which were only being picked up by the far field signals. So this was an inappropriate shock for AMI. This is case 3. This is 60-year male who had VT for ARVDC and then had the dual chamber ICD for secondary prevention. So this patient basically came to us.
Doctor, can we have a little discussion on the first case? Little, huh?
Yes,
No, I think what was the impedance of the lead? Because when you have this kind of a shock, inappropriate, whether there is any kind of a
No, sir. Impedance of normal, sir, 585. This was actually patient was
impedance of the ICD coil or the
normal, sir.
That was also normal. Okay.
It was also normal, sir. The shock impedance and then patient's impedance was normal. This was actually welder, so he was doing welding, during which the signal was sensed.
Now you said he was on the rainy day.
So that was second case, sir. The first case was a welder who had inappropriate signals in both the channels, which were appropriately diagnosed.
That's expected. Okay, thank you. Thank you. Okay, please go ahead. Carry on.
So this was case 3. Basically, ARVDC patient had a VT and then ICD implanted for secondary prevention. And then patient on recent routine device interrogation in the clinic showed to be normal. And then this is called as interval plot. So the normal parameters like P wave amplitude, R wave amplitude, impedance threshold, everything was normal. But if you look at the interval plot, what is happening is the device is detecting multiple high rate non-sustained episodes. And then if you look carefully into the interval plot, so the full thickness circles are ventricular channel signals, and then the empty boxes, square boxes, are atrial channels. So if you see, there is sudden drop in atrial rates. So there are very rapid, more than less than 150 interval, which is almost non-physiological. And then, but ventricular rates are normal. So this thing is happening multiple times and bizarrely, and the episode terminated intermittently. So let's look at intracardiacs. So this is intracardiacs. The top channel displayed is RV coil to can, which is far field. The second one is RV tip to ring, which is near field. And the third one is Markle channel. If you see, like what is being seen to us is there's a very high frequency, like in the first case, and then non-physiological, almost instantaneous in both the channels. But what is happening to the device? What is device seeing is actually it is seeing only the signals in the atrial channel, not the ventricular channel. You can see there's undersensing of the these non-physiological external signals.
The top one there is the atrial channel, not the RV coil to can.
Oh, sorry. Yes, sir. It's atrial channel, not RV coil to can. So the first one is atrial, the second one is near field, and then this is Markle channel. So basically the device is able to detect the signals only in the atrial channel, not in the ventricular channel. And which is why the device is not able to label this event as noise, but rather because there are very high episodes, it labeled it as, and which were non-sustained, it labeled it as non-sustained high rate episodes. These are all intermittent. So the actual, the device diagnosis, which was inappropriate as non-sustained high rate episode, but actual diagnosis EMI with undersensing in the ventricular channel. So this is other case where a 55-year male, he had a DCMP and then underwent a post-CRTD. He came to our clinic 10 days prior, which was normal interrogation. Then after 10 days, he presented to emergency with multiple ICD shocks. So this evaluates, this example shows the significant importance of lead parameter trend analysis. So you can see on the left upper channel is ventricular pacing impedance, and then left lower is R wave amplitude, and the right side upper lower are respectively defib impedance and then SCC coil impedance. So what is happening here? So this green arrow shows the last session, which was normal basically. And then suddenly he had a impedance of pace sense coil shooting up from baseline to more than 3000. And then at the same time, if you see the R wave, which was 8.1, dropped down to 0.6 abruptly. This change, which is abrupt, is very important. And if you look at defibrillator impedance, and SVC coil impedance, they were normal. So when we analyze the intracardiac EGMs, the top one is RV tip to ring and the second one is RV can to coil. So basically far field and near field and the marker channel. So you can, what we can see here is the near field is showing multiple signals. So variable morphology, variable amplitude, and variable frequency. And these were all non-cyclical, which means continuous. And then these are also non-physiological intervals. If you see, there are like almost less than 150 millisecond intervals in near field channel only. And the far field is clean. And you can see some signals are saturating the amplifier. So all these 5 features are features for conductor fracture. And because you are seeing only in the near field, you can we can say that the fracture, the conductor fracture is in the pace sense lead. So normally, if you take a cross section of the ICD lead in a dual coil, you will see SVC high voltage coil, and then RV high voltage coil, and then you will see one sense coil and one pace coil, and you will have inside insulators and outside common insulator. So the problem here, because we had SVC coil and RV coil impedance normal, and the signal being normal in the far field, we had problem in sense coil and pace coil, basically due to conductor fracture. So this is other patient, 43-year male who had single chamber ICD for secondary prevention, presented with multiple shocks. On routine parameters were normal. So intracardiacs, the top channel is near field and the second channel is far field, and bottom one is marker channel. So now here we can see organized activity which is being seen both in near field as well as far field. And then the device appropriately labeled it as VF because this was in the VF zone, and then gave appropriate shock. So this is appropriate ICD shock and appropriate function. So through these examples, I just wanted to analyze, suggest the importance of analyzing intracardiac EGMs, and then looking at interval plots, and then lead parameters, and especially the trend. So another important thing is the clinical setting is very important, as we have reproducibly produced the same effect. So it's always important to take the history, and if possible to do a maneuver which can replicate the same thing, and then looking appropriately the EGMs and then interval plots and lead parameters. Thank you.
Thank you for that nice presentation. I want to ask you a question that, see, for this myopotential oversensing, do you always need to have some insulation break to have it, or with an intact insulation still you can have a myopotential oversensing?
Myopotential oversensing can be seen with intact leads also, sir.
Intact insulation also.
Yes, sir. But it
because
should be
often, yeah, because often in leadless ECG, if you see a myopotential thing, often we find that the impedance has gone down, and then usually that vector corresponds to the pectoral muscle. So if you have maneuvers to stimulate the pectoral muscle, you have the myopotentials there.
Yes. And those will be cyclical also.
I think leads remain the weaker part of the whole system, even more than what it means for the pacemaker leads. And about 10% could be the incidence over 10 years that the ICD leads, the integrity issue comes up. So that's because these leads are, as you can see, heavy leads, and naturally they're more susceptible to integrity issues, either insulation or conductor fractures. Okay.
In that EMI thing where you had this EMI picked up only in the atrial lead, and then ventricular oversensing, ventricular lead was not showing any signals. What is the reason? Because is it the autogain settings or something? Because here you see that some gain adjustment or something, the ventricular lead is not picking up the signals or something.
It could be because of 2-3 reasons, sir. One, the sensitivity and the decay in sensitivity is different for atrial channel and ventricular channel. And the other thing is filter settings are also different for ventricular and atrial channel. Probably those were the reasons, I think, for which the ventricular channel is not being sensed the signals, though it is seen.
Thank you. We'll move on to the next presentation, I think, by Dr. Jaskaran Singh Gujral.
Dr. Jaskar?
Am I audible?
Yeah.
Yes, sir.
So here I'll be discussing about diagnosis of VT and SVT in. Firstly, I'll be discussing about single chamber ICDs. Single chamber ICDs, we have only three discriminators, that is onset, stability, and morphology. So let's start with an interval plot. This is an ARVC patient who got a single chamber ICD. Now, the way to do it is, first thing you check at all the three zones that are available. They are mentioned up here, VT, fast VT, and VF zone. They correspond to the horizontal lines that one sees here. So one sees here this field of circles. This correspond to the VV interval, and they are falling between the VT and the VF zone. So what next happens is that VT happens here. A burst is given. You see around 9 to 10 beats, and which is faster than the VT. VT continues at a similar rate. Then you see another burst happening, which is faster, which is slightly below this horizontal line. Then you see again VT continues at a similar rate. Then you see a different kind of ATP being given. This is RAM therapy because gradually the RR intervals are shortening. So, but now the VT has accelerated, as we saw, 2 to 4% can cause acceleration. And then another RAM given, which ultimately leads to termination of VT. Why? How do you say termination? Because now the rate has gone, the cycle length has increased, it has gone into sinus rhythm. Now let's see the corresponding electrograms. So first we see the near field EGM up and the far field EGM here. So we see near field EGM should not be used for discrimination. They may be narrow, they may be wide, they should not be used. Far field EGM, they give some idea, but that is only with respect to the normal sinus ECG. If you have a normal sinus EGM, then you can compare it with them. So we see here a constant regular tachycardia. This is a zoomed up view. So you see TS, tachycardia sense happening. It is happening at a very constant rate. 10 to 20 millisecond variation is there. Then first in the upper column, you see tachycardia pace. This is ATP. It is trying to revert, but the tachycardia continues. No change in the cycle length. 410, 410, 430. There is some variation, but no acceleration. Then again, there is another ATP happening. This another ATP. Same tachycardia continues at a similar cycle length. Then a third ATP in the below column. So this is faster, and this is RAM therapy, as you see, 290, 280, 270, 260. And then what one sees here, this is the fourth ATP which happens here. So there is acceleration of tachycardia in this area, and earlier it was 410, 420, 430, but now it has become 340. And then finally, after this third RAM, what happens is there is termination of tachycardia, and you see sinus rhythm. Now one can compare these signals as compared to these signals. So you can see the far field EGM is wider as compared to this EGM. So how does the device see it? This is the report that we get with the EGMs. So the sequential way to analyze it would be, first, see the parameters. So one sees up, this is the VT zone. So you compare the rate and duration of the VT that happened, that is at the top column. The median rate is 420 milliseconds, which is less than the 470 that has been set. So the rate is satisfied. Then you see the duration. The duration here is 76 beats. It will come out to be around 40 seconds. So the duration is 1.5 minutes. So rate and duration are satisfied. Then it goes on to its three discriminators, that is onset, stability, and morphology. In this case, stability was off because this patient was an ARVC patient, was getting frequent PVCs also. and that is why stability was kept off. Onset was on, the standard setting of 81%, and morphology was also on. So by onset was sudden. So this is a sequential, this is a Medtronic device. So first it checked onset. Onset was sudden. So it labeled it as VT. The second thing it checked stability, stability was off. Third thing it checked morphology. So morphology match, as sir discussed, it is kept around 70%. And what was the morphology match in this case? It was multiple matches made during the VT. All of them are less than 70%. And we also saw physically that the morphology of the VT and sinus rhythm are different. So this device made an appropriate diagnosis of VT, which terminated after fourth bout of ATP. And this is how the morphology match enhancement. This has already been discussed. So this is the dual chamber ICD, which makes life slightly easier for us. If you see here the 8 RA near field channel, this is the RV near field channel. Here one can see very clearly that the ventricular rate is more than the atrial rate. So V more than A, straight away it means VT. What happens next is device tries to give ATP, does not succeed. Again, tries to give ATP, does not succeed. And then it delivers a charge enabled CE. If you see carefully, there is CE also written along with VS, and then charge is delivered. You see a saturation artifact here, after which A sense B pace resumes. So this is how appropriate diagnosis of VT is made by a dual chamber ICD. Here in this case, V more than A suggests VT. Now this is a third case. In this case, the upper EGM are RA near field, the lower are RV near field. One can see regular and one can see irregular atrial activity, cycle length of around 250 to 280. There is some irregularity here. And then you see V pacing going on. So this is a patient of CHB who is having AFib and a flutter of fib. So ASS here V pacing is going on. Then something happens here. In this area, one sees suddenly there is an increase in the rate of the seen in the RV near field channel. So how does the device see it? Now device sees regular RR intervals are here, and however the PR intervals are variable. So as per the device, if you have regular RR intervals in a dual chamber ICD and the PR intervals are changing, then this has to be VT. And physically also we can see that if there is a sudden onset increase in the ventricular rate, there was V pacing going on, there is sudden onset increase in the ventricular rate, it can be nothing but VT. So this particular case, there was dual tachycardia and the correct diagnosis of VT plus SVT was made during. So this is a third case, a slightly tricky. So here again we see RA near field and RV near field. So one sees here, we don't have the onset here. What we have straight away here is tachycardia pacing. First, we must see at the normal EGMs here. So this is tachycardia going on at a constant rate of around 380 milliseconds. So at this point, it can be anything. We don't have the far field. We don't know whether it is wide or narrow. So what happens here is, first an ATP is given. What happens during ATP, one should observe the marker channels. So marker channels 310 milliseconds, one sees that ATP has been administered at a faster rate as it should be, but the atrial channels are running at the same rate. So there is no change in the atrial channel intervals, which means the ATP is not being, the atrial channels are not being reset, the atrial electrograms are not being reset, which means AV dissociation is seen here. Then a second run of ATP given here, tachycardia pace here, and this terminates the tachycardia. So one may see, just by a cursory look, one may say that, okay, ATP has terminated tachycardia. There is some VA dissociation, so this might be VT. But if you see carefully here, since if suppose this was ventricular tachycardia, then the atrial rate should also have been accelerated to the same cycle length. And if it was sinus, the rate was it's not corresponding to sinus. So both of these findings suggest that this was indeed atrial tachycardia, which initially was not entrained with ATP, and later on this atrial beat, this ATP got transmitted to the atrium and terminated the tachycardia. The bottom message is that if a tachycardia gets terminated by ATP, it does not mean it is AT. And in this particular case, why the device faulted was because there was no morphology match here. This tachycardia was sudden onset. It had regular RR intervals. So onset and stability were met. Morphology was not activated. So that is why it misdiagnosed this tachycardia as VT. And physically, you can see the EGMs are similar. EGMs are similar in during tachycardia and during sinus rhythm. So this was the case of AT. The last case, this is a interval plot. Again, one may see here sinus rate is going on. You can see two dots here. The VV intervals are pulled up circles and the squares are A intervals. So you see here sinus rhythm going on because so suddenly what happens? Suddenly one may say that this is a PVC, and then suddenly the rate increases. So on the first look, this appears that suddenly you can't see any atrial electrograms, and you see only ventricular electrograms which are in a VT rate. So one might say that this is VT, but one must also look at the EGMs of what is the correct answer. So if you see here carefully, this is the EGM. So this was what was happening. So this is a 1:1 tachycardia. There are signals in atrial channel as well as ventricular channel. However, the atrial channels are not being seen because they are falling in the post-ventricular atrial blanking phase. So they were not seen by the tachycardia. The hint to this in the interval plot was the sudden disappearance. Sudden disappearance, although VT with sinus arrest could be there, but a sudden disappearance of the atrial channels was indeed a hint that this was a false reading, and this could have been AT or AVNRT or even VT with 1:1A, but definitely most unlikely was VT in this particular case. Thank you.
Thank you, Dr. Jaskar. Jaskar, I want to ask you your third case where you mentioned that ATP terminated it was atrial tachycardia.
Yes, sir. Yes, sir.
How could in such a case, what kind of programming as sort of a parameter that you may choose to prevent this? Is any suggestion on that?
Sir, in this, probably, sir, I'm not really sure, sir, but probably medical therapy and ablation would have been better options.
Or
maybe
I think one thing I would do, I mean, this device obviously did not have a morphology. One thing I would do is give beta blocker to ensure that the atrial arrhythmia conduct rapidly.
I think you control
Yes,
it
yes,
with this medication.
Yes, sir.
This is unusual, but you're right, it can happen. And I think looking at the EGM might give you some idea, careful study of that. Okay, I think open to comments and questions. Jeet, you want to say something? Dr. Jeet?
No, I think Jaskaran has showed some appropriate and inappropriate ICD functioning. I hope the audience has got the idea. I think if you have enough audience remaining, maybe you can go to that last case, which is a small one. Yeah,
I think we can go.
5 minutes there, we can quickly go.
Yeah. So next case presentation.
I thought he has done it already, is it not? It's a size. You have one more case. Okay, quickly, Sai.
This is a short case, sir. Basically, this is 54-year male who had resuscitated VF, and then it was structurally normal heart, underwent dual coil single chamber ICD for secondary prevention. He basically presented to us with recurrent ICD shocks when he was playing badminton and there was an argument in between players. So this was the interval plot on analysis. You can see that there was sudden onset drop in intervals, which means tachycardia. And then there was a It was programmed for 6 ATPC and then ICD shock, sir, in a single zone, in 3 zones you can see here. So what is happening here is, so here first burst ATP and then second burst ATP and then third faster burst ATP. And then you can see this is ramp ATP, ramp ATP, ramp ATP. So interesting thing you can see from the interval plot is immediately after burst ATP, you can see suddenly the rate is slightly slowing down and then it accelerates back to usual rate. And then ATP, the same thing happens, the same phenomenon. And then because the tachycardia didn't terminate and then device gave shocks. So on EGM analysis, this was single chamber ICD. So and the morphology match was on and the onset and then stability. These were the 3 parameters which ICD looks into in single chamber ICD. And then all were satisfied. So it started counting consecutive counters and then it was satisfied and then VT was detected and then it gave ATP. And then if you see immediately after ATP, this is what was happening, slightly slowing of the rates. And then it again warms up. The same phenomena keeps repeating every time after ATP. And then multiple shocks were given to him. This was further EGM analysis after ATP. You can we can see that the rates are slowing down. And then finally it was out of detected VT zone. It was in VS zone normal. So, but the morphology was almost same. And then we thought it could be because he was playing and there was an argument. The clinical setting, and then it was stable. So we thought it was not like the clinical VF which he had. So we thought it could be probably atrial tachycardia versus sinus tachycardia. And then we thought, why did the device shock this patient? So, and we looked at the morphology match. This was his, basically more than 3 didn't match. So, and the template we analyzed, the template which was given to analyze morphology. So this was his template. The problem here was, and then the template alignment happens with peak to peak alignment in Medtronic. And then when at the peak, if you have 2 peaks, especially, then that can lead to misalignment of the template. So this is what is happening here. So though the morphology was exactly same, just because the peak of it had 2 peaks. So, and then the initial peak was slightly taller than the later peak, and when there could be, and this can lead to malalignment of the template and then lead on to morphology mismatch. So this was happening in this patient. And what we did was we changed the template. So initial template was from RV coil to CAN. Then we changed it to SVC coil to CAN. And then the parameters were adjusted. And then we made him to run on a TMT and then look in the device. And this time it was exactly same, but the morphology and the device appropriately diagnosed it as not a VT. So, and the match was more than 70% in almost all the EGMs. So I just wanted to say that template alignment is important in morphology discrimination. So whenever you are choosing a template, make sure that the peak is only 1 peak and appropriate. Thank you, sir.
Thank you, Dr. Sai. Very interesting. Ashish, do we have more time or it's already?
Sir, Ashish sir is not there, I think, now. So I think we can, we have discussed all cases, so we can discuss some other comments, sir, if you have anything.
But do we have, Suchit, we do have more time because he said 12:40.
Yeah, we can close if we have finished our this meeting presentations.
Okay, I'll just like to make 2 comments about the morphology. The morphology is visible in Medtronic and St. Jude all models, and Boston, the newest model. The morphology is not visible in Biotronic. So this thing that Sai just told, that applies only to the Medtronic and the St. Jude and the newer models of Boston. You cannot see the morphology in the other models. The other very inappropriate programming about this patient was that he did not need to be treated for 18 beats NID at 150 beats per minute. That I think was more glaring than the morphology map. It is because of that inappropriate part that he actually also got the shock.
Any other question from anyone else?
I just like to ask, you are all, what should be our approach? Should, I mean, a patient for a primary or even for a secondary, unless there's a reason for atrial pacing, should we really go for dual chamber ICD or just a single chamber ICD? Does this adding the dual chamber really helps to sort of issue of inappropriate shocks?
No, sir. I don't think adding an atrial channel really helps for discrimination, except in two situations. A patient who's likely to have a very rapid AF, which conducts down to the ventricle, like a Brugada syndrome, a young patient, or the other end of the spectrum, people who have very slow VT, where it's difficult to differentiate from atrial versus SVT versus slow VT. Except for these two situations, I don't think an atrial lead actually helps in discrimination.
You think in Brugada, all patients should have a dual ICD, chamber ICD?
No, I think if a young patient with Brugada gets an or HCM or Brugada with young patient, especially HCM, I'd say more of HCM. Young people who are prone for atrial fibrillation and also prone for rapid conduction of atrial fibrillation, I would prefer a dual ICD. I'd prefer an atrial lead for discrimination.
I mean, you may be right in a secondary issue, but in a primary issue, we don't know what kind of a reason.
In a primary, it's hardly, it's difficult to justify.
I think this is what I wanted. I think once, I mean, single chamber ICD probably may be as good in practice as the.
I agree. Except for maybe that slow VT versus atrial tachycardia. And slow VTs ideally should be ablated, not treated with an ICD.
Yeah. Anyway, I think we have already crossed time. Anybody likes to, Suchit, you, any final remark from you?
I think we have great pieces from Dr. Sachin's group, and everyone has presented excellently. A lot of learning for me also. So I think all good things should come to an end, and I think I will thank. I will thank Professor Talwar sir and Dr. Ajit Sachin sir and Dr. Ashish Navar sir, Rakesh Jadhav sir, and all my seniors and teachers, and also the all DNB trainees who have been with us in this time and have learned from this. I think they will use it in their practice to their limitation. One thing is very important, please learn to program yourself. Don't depend on device company representatives. Once you handle that thing yourself and do all programming yourself, be it in the middle of the night, just unlock the key, take the programmer, come to the patient and do the programming. Once you do the programming, understand it yourself, then you will have a better idea. So this is your task after this meeting. So let's close it, sir. Anything more?
Well, and just special thanks to Jaskaran as well as to Dr. Sai for their sharing such important good cases.
Yes.
Thank you.
Thank you,
Everyone.
Thank you, sir. It was a pleasure. Thank you, sir.
Thank you.
Ajit sir, anything?
No, that's it. I think we have already overshot the time, but I think you learned something useful. Thank you.
Thank you. Thank you, everyone.
So let's close the meeting now.
Okay. Thank you, Sachin. Let us go. Thank you all.
Bye.